Oops. Okay, so just to let you know, for conflicts of interest, I have received research funding from Amgen, but no other conflicts apart from that. Today, what I really like to talk to you about is do a review of the evidence for osteoporosis therapies in older adults. And I also wanted to focus on a couple of special populations that I often get a lot of questions about from primary care practitioners and a lot of our residents as well. And that is patients who fall frequently and also patients with dementia. And then I'm also going to touch about the role of ortho-geriatrics in hip fracture care. And that's something that is a special interest of mine and very close to my heart. So I thought I'd start off with a clinical case, and this is an adaptation of a case that I had a discussion with one of my colleagues in primary care only a couple of weeks ago. So this is an 81-year-old gentleman. He does have a history of mild dementia. I practice in London, and in our surrounding areas, we have a lot of farms and rural areas, and we have a lot of aging farmers who are developing dementia, but are very ingrained in their routines. So this particular gentleman goes out to feed the chickens in the barns every single day, rain or shine, snow, ice, sleet, etc. And because of that, he's fallen 4 times in the last 6 months. One of the things that compounds that is that he is supposed to use a walking aid, like a rollator walker, but he often forgets to use that because of his dementia. His only fracture history is that he broke his wrist 10 years ago, and he has no other significant risk factors. So his primary care practitioner very rightly went off and did some spinal x-rays and didn't have any evidence of vertebral fracture, and then went on to do a bone mineral density scan and found the femoral neck T-score was minus 2.6, and his lumbar spine was positive 0.1, but with some evidence of degenerative change there. And then she went on to do a FRAX score, and that gave him a major osteoporotic fracture risk of 16% over the next 10 years, which puts him into the moderate risk category. And his hip fracture was 3.5%, so just into the high risk category. So her question to me was, should I treat this man or should I not? Given that he's got dementia, he's got other comorbidities, a lot of times what we do in geriatric medicine is try to rationalize medications and reduce polypharmacy. Should she be adding in an extra medication to somebody who is only moderate risk on FRAX for major osteoporotic fracture, and his last fracture was 10 years ago? So I'm just going to go through some of our decision making and thought process through that. So before I get into the pharmacological therapies, I just wanted to set the scene for you about fractures, osteoporosis, in the aging population. So we know that osteoporosis is predominantly a condition of older adults, particularly postmenopausal women, and that's when your risk really starts to go up. But your risk of fracture increases with age, and that's regardless of whether you're a woman or a man, although women have a higher fracture risk than men. And this is a graph that may be familiar to a lot of people, which outlines the fracture continuum. So on the left-hand side, on the x-axis there, you have increasing age, and on the y-axis, you have morbidity associated with various types of fractures. So often, people start to develop osteoporotic fractures around their 50s to 60s, often starting with a rib fracture and then moving on to higher morbidity fractures like pelvic fractures, vertebral fractures. And then finally, the hip fractures tend to occur in the eldest population, often in the 70s, 80s, 90s. I think the oldest people that I have looked after, I think, was 104. And I'm sure that there are older patients in that as well. So hip fractures are the ones that pertain the highest degree of morbidity and mortality, and the vast majority of them happen in older adults. So over 60% of hip fractures are in patients who are over the age of 80. When you're 80, you have like a 20% risk of hip fracture, and by the time you get to 90, that goes up to 50%. And 30% of hip fractures occur in men. And this is a problem, not just in Canada, but across the world, because the population of the world is aging. And you can see here, compared to 1921 to 2041, the projected population is that nearly a quarter of Canada's population is going to be over the age of 65. And the 75 to 84 and 85 plus age groups are the ones that are going to be growing at the fastest rate. And these are the people who are going to be at highest risk of developing fracture. And with those projections, we can see that the incidence of hip fracture is going to go up quite significantly. In North America, we're looking at a doubling of the number of hip fractures between 1990 and 2050. And down over in Southeast Asia, there they have a veritable tsunami of hip fractures that is about to hit them. So, what do we do about that? I think there's really a two-pronged approach to this. Firstly, this is a study, an epidemiological study projecting hip fractures from the early 90s. So, this is where the osteoporosis care gap and the need to reduce that care gap and ensure that people who are at high risk of fracture on appropriate treatment to try and reduce the number of hip fractures that occur. So, that's one prong of the approach. The second is that we know that there is a significant gap in osteoporosis care, and there will be an increase in the number of hip fractures that we see. So we need to make sure on a local, provincial, and national level, and even an international level, that we have the resources that are required to care for these patients as best as we possibly can. And we also know that hip fractures are expensive, and putting our first priority is going to be patient-centered care. We want to make sure that patients don't suffer unnecessary harm if it's not necessary, making sure that they have appropriate treatment. But of the patients who do suffer hip fracture, we want to make sure that we do the best that we possibly can for them. But from a national economic perspective, they are very expensive. And what we're seeing now is that we're having a reduction in the number, we have an increase, sorry, in the number of older adults who are going to be dependent on the working age population. So this is an example of an old age dependency ratio, and all countries have them. And what it shows is the number of dependents, so either youth who are too young to work or seniors who have retired out of the working population, and the ratio of these people who are dependent on per 100 population of working age. So we can see down here in the 1970s, we had about 15 seniors who are reliant per 100 population of working age. And as that aging population increases, by the time we get to 2056, we're looking at 50 seniors per 100 population of working age. So that's going to be a huge number of older adults, depending on the taxes and income and uh, um, economic work that is being done by this working age population. So to be able to manage the financial burden within the country, we need to make sure that these seniors stay as healthy as long as they possibly can to reduce the economic cost of that. And we know for every hip fracture, it costs about $20,000, and about a quarter of the patients with hip fracture are discharged to long-term care with a cost of $600 million per year. So if we can improve hip fracture care to reduce those costs and to reduce the number of patients to discharge to long-term care and help people to maintain their independence and go back to living within the community, that's beneficial not just for the patient, but also for the economy as a whole. So that is kind of setting the scene for what we have projected coming with regards to hip fracture over the next couple of decades and the importance of why we get this treatment right. So one of the questions that I often get is my older patient, they're multi-morbid, there's a lot of problems. Will they actually benefit from treatment? One of the things that we consider a lot in geriatric medicine is the drug trials themselves. So a lot of times older adults are not included in drug trials. The results of which are extrapolated into our patient population. Some of the older, frailer patients, long-term care patients in particular, are not included within the trials. So I want to go through a little bit of the evidence to show you what we do know about the osteoporosis treatments, particularly in the very old. So whenever I make clinical decisions about whether or not to treat somebody, I think that there's two things that I think to myself all the time. The first one being that fractures hurt at any age. Whether you're 25 or 55 or 85, if you suffer a fracture, it is painful and it is not pleasant. And if anything, the older you are, and the frailer you are, and the less physiological reserve that you have, I would argue that these are people who are more likely to have worse outcomes from fracture and long-term sequelae and have difficulty recovering from it as compared to your fitter, younger uh, adults who have less medical issues and are less frail. The second thing that I get asked a lot is, will they benefit from it, and is it within their goals of care? And I think that this is a really important lesson in shared decision making, and what matters most to the patient. So here on the left-hand side is the five M's of geriatric medicine, and this is basically our bread and butter of the commonest things that we deal with. And you can see there on the thumb, the most important one is matters most. So, what matters most to the patient? And I think this was really brought home to me at a workshop that I was attending on osteoporosis care in long term care. And there was a patient advocate there, and we were discussing the long term care guidelines, and particularly one of the suggestions that if your patient's life expectancy is less than a year, then they may not benefit from treatment with osteoporosis therapies. And she did give the healthcare professionals there a lot of pushback because she is actually a long-term care resident. She's an osteoporosis advocate, and the couple of points that she made to us was that, firstly, in her experience, healthcare professionals are terrible at predicting what somebody's life expectancy is, and there is evidence that particularly patients with chronic illnesses that are, fairly well managed, and particularly progressive dementia, it can be difficult to, time exactly how long somebody has left and whether that's going to be within 1 year or not. And she also said, you don't know how important fracture prevention is to me. So I would like to be involved in those discussions about whether or not I would benefit from osteoporosis therapies and what are the risks to me starting these medications. So basically, no decision about me without me. And that's something that I've really taken to heart. That being said, this is a outline of all of the medications that are currently available to us. It may be familiar to you from the Osteoporosis Canada website, and I have taken the liberty of adding Romosozumab to the right-hand side there, which has recently been approved by Health Canada. So often we will start with our anti-resorptive therapies over here, either bisphosphonates or denosumab. We don't use raloxifene or hormonal therapy in our older adults. These tend to be used in younger perimenopausal women. But we do sometimes use our anabolic agents as well, and they can be of benefit to older adults. So I'm just going to go through all of the medications one by one. But firstly, I wanted to show you the inclusion of older adults in the pivotal trials. And as I mentioned, this is something that often comes up when we do Journal Club and how relevant it is to our population. And because I think osteoporosis is a condition that predominantly affects older adults, we do have fairly good representation of the older population in a lot of the pivotal drug trials. So alendronate went up to 80, and that was one of their earlier drugs. But you can see, with zoledronic acid, denosumab, and romosozumab, that the patient inclusion does go up to the age of 90 and often starting around 60 to 65, which I think is representative of a lot of the patients that we see. And the proportion of patients who are older is also a good number. So zoledronic acid, nearly 40% of patients are over the age of 75. Three-quarters of the patients in the denosumab trial were over 70, and again, a third are over the age of 75. And romosozumab, about a third are over the age of 75 as well. So with regarding bisphosphonates, we do know from well-established data that we have good fracture risk reduction with bisphosphonates, and these are the numbers that we get after 3 years of treatment for alendronate, risedronate, and zoledronate. So vertebral fracture risk reduction can be anywhere from 40 to 70%, hip fracture reduction from 40 to 50%, and non-vert fractures from 20 all the way up to 40%. Now, there have been some very helpful Cochrane reviews of both alendronate and risedronate, and part of those reviews was looking at the efficacy of these treatments stratified by the type of fracture, whether it's primary or secondary prevention, and also efficacy by age, and they worked out a number needed to treat. And what you can see in these graphs here that I've highlighted is that as you get older, because your fracture risk increases so much, the number needed to treat to prevent a fracture actually declines fairly significantly as a person ages. So the older you are, there's actually more reason to have somebody on treatment rather than a younger adult. So here, for example, for secondary prevention of a vertebral fracture when you're in your 50s, your number needed to treat is over 400. But by the time you get into your 80s and 90s, you're talking about 12, 11, and all the way down to 8. And we see similar patterns with hip fracture as well. So in your 50s, because it's not very common, people have, fairly better bone density and less of those other risk factors. You're looking at like 400, 900, but again, in the older ages, you're going down to 8 or 9. And the same could be seen with risedronate as well. The same sort of pattern with reduction in the number needed to treat to prevent a single fracture for vertebral, non-vertebral, and also for hip fracture, down to numbers less than 20, and in this case, less than 10. There are practical considerations that we need to take, though, when we're thinking about prescribing bisphosphonates, particularly oral bisphosphonates in the older adult. A lot of them do tend to be frailer with more comorbidities. With advancing dementia, you may have problems with swallowing. If you've got cerebrovascular disease, history of stroke, neurological conditions, swallowing again may be a problem. And oral bisphosphonates often need to be taken either once a week or once a month with a full glass of water sitting in an upright position, not to eat and drink for half an hour to 45 minutes afterwards. So if I have anybody who has any kind of swallowing issues, they need to have a modified diet and fluids, then oral bisphosphonates are probably not the drug for them. If their cognition is such that they won't be able to remember it and they don't have the support of a caregiver for administration, it can be a problem. And if their mobility and transfers is such that sitting in an upright position is difficult, then that is also likely not going to be a suitable medication for them because they're a higher risk of GI side effects. And I always remember one of the things that one of my mentors told me specifically about administration of bisphosphonates in long-term care is that applesauce is the enemy. Do not crush bisphosphonates and put them in applesauce for administration. I've seen that done fairly frequently. Equally, it is not advisable to crush bisphosphonates and put them down a feeding tube because they won't be efficacious and they will likely block the feeding tube as well. So other things to think about are, drug noncompliance, particularly oral bisphosphonates, can be fairly high. Potential side effects we're often very aware of. And also, as you get older and you accumulate comorbidities, and we also know that renal function declines with age, they're more likely to have renal dysfunction and CKD, which would make them contraindicated in GI pathology. And if that is the situation, then you're much more likely to benefit from parenteral therapy, either subcutaneous or IV. And that brings me on to Denosumab, which is a subcutaneous medication. And again, we had fairly good representation in the FREEDOM trial of the older adults. And I'm not going to go through it all, but we do know, again, that we have good evidence for fracture risk reduction with Denosumab from the FREEDOM trial. Now, this is a trial that was published last year, and it is a fairly small retrospective cohort study that was completed on Korean women. But it was really looking at the effect of Denosumab in the super elderly patients. And by that, they mean patients over the age of 80. And this study was meant to be looking at the safety of Denosumab as well as efficacy with regards to increases in bone mineral density. The sample size was not large enough to be powered to look at fracture risk reduction. That being said, the findings were that there was a significant increase in bone mineral density at the lumbar spine, the femoral neck, and the total hip in patients over the age of 80. And even when they looked at the subgroup of those patients and looked specifically at patients over the age of 85, those significant increases in bone mineral density held true. They also looked at bone turnover markers, and they did find a significant reduction in CTX across all of the age groups, similar to what you would find in the younger age groups. With regards to the tolerability and safety of the medications, there were no cases of significant hypocalcemia or adverse events that required discontinuation of the Denosumab. That being said, I would point out that when we looked at the renal function of the cohort, they had fairly good kidney function. Their EGFR was an average of 70. And they were all vitamin D replete and also supplemented with vitamin D throughout the study. which would reduce the risk of hypocalcemia. So practical considerations for denosumab, it is very easily administered. Once every 6 months is generally not too onerous for most people. I find that a lot of retirement homes will administer denosumab there, so it saves them a trip to the family doctor. Depending on the home, there may be a small fee. Long-term care homes have no difficulty administering it. Here in Ontario, it is covered by our provincial drug coverage plan, and it can be used in patients with chronic kidney disease, although I would caution against using it in patients with um, a more advanced chronic kidney disease, so stage 4, stage 5, or dialysis patients, as they are at higher risk of hypocalcemia. Other considerations, though, is that it is a reversible drug. And if you stop somebody who's been established on denosumab therapy, they are at higher risk of multiple vertebral fracture on discontinuation. So we know from the Phrygian trial we have good evidence of use for patients at least 10 years with increased bone mineral density and continued fracture reduction. So in my very elderly patients, I often tell them that this is going to be a lifelong therapy. Next, we have teriparatide, which is recombinant human parathyroid hormone, which is our first anabolic drug and is particularly good for a reduction in vertebral fracture as well as non-vertebral fractures and glucocorticoid-induced osteoporosis. The original fracture prevention trial didn't actually state the ages of the patients who were included, but it was reported in a subsequent subgroup analysis of the fracture prevention trial. So the patients recruited were between 42 and 86, I believe. And in this subgroup analysis, they looked to see whether there was any difference in outcomes depending on the age of the patient. And they stratified patients to less than 75 or 75 and older. And they were looking at safety and efficacy again. So the effect of the teriparatide on bone mineral density of the lumbar spine and femoral neck, it's just fractures, bone turnover markers, and safety. And what they found was that there really wasn't any significant difference in their outcomes, regardless of whether you were under 75 or over 75. Both of them had increase in bone turnover markers and specifically bone-specific alkaline phosphatase within the first month of administration of teriparatide, suggesting that there was an increase in bone formation within that shorter period of time. No difference in femoral neck bone mineral density, and also no difference in incidence of fractures, height loss, hypercalcemia, or hyperuricemia. The only difference, significant difference that they did see was in the lumbar spine bone mineral density of the placebo groups of the patients under 75 and over 75, with the placebo over 75 group having a higher bone mineral density. And that's postulated because if the older you get, the more degenerative change that you accumulate in the spine, and it's likely that that was causing that signal. There was no difference in adverse events, and when they did a subgroup analysis of the over 80s, again, the number of adverse events was similar to all of the other groups. So the conclusion there was that in your older adults, teriparatide appeared to be equally efficacious as your younger patients, with no increase in adverse events seen. Now, the practical considerations for teriparatide, again, as you get older, you tend to accumulate more past medical history, and there are various contraindications to it that may, and if they've had any of these, that may exclude them for use. It is a daily subcutaneous injection for 2 years. So then again, you need to think about things like dexterity. Are they able to inject themselves? Do they have the cognition to be able to do this? And if not, do they have the support of somebody who can help them? And often the thing that affects a lot of my patients, particularly as I mentioned, we have some more rural areas, and we're not necessarily the most affluent as compared to some of the big cities. It is a very expensive drug, and we have no provincial drug coverage for this. Although recently there is a generic form that has come to market, which is a little bit more affordable. And I think as a consequence to this, I have also had much more success in gaining compassionate coverage through Eli Lilly, who manufacture Forteo. And the newest kid on the block is Romosozumab, which is a monoclonal antibody that inhibits sclerostin. I'm not going to go into the frame and the arch trials too much because I know that those have been spoken about before, and I haven't seen any specific subgroup analyses into older adults as yet. But as I mentioned, they did have a fairly good representation within the trials of patients up to the age of 90. So I hope that was a nice little summary of the pharmacotherapies that we have. So I want to go now into some of our special populations, if I call them, and the considerations that we need to give to them. So this is a question that I get very often that's reflected in the clinical case that we spoke about to begin with, which is, my patient is falling, but falls isn't a risk factor on FRAX. So does it matter? Do I need to do any adjustments to my FRAX, or is that kind of not really a thing? So we know that osteoporosis is common in older adults, and we also know that falls is fairly common as well. And I always tell my learners and my residents, the two of them go together. If you're doing a fracture risk assessment, ask about falls. If you're doing a falls assessment that we do in geriatric clinic often, even if they haven't had a fracture, do a fracture risk assessment because the two will always go together. It's very common. So, 42% of patients 75 or over will have a history of falls, and they count for over 50% of the injuries that occur among seniors. It's the leading cause of fatal injury among seniors, and about 5 to 10% of falls will lead to fractures, and 1 to 2% of those will be hip fractures. Now, when I'm thinking about one of my patients who is falling and how I interpret that in whether I need to treat them, and how significant their falling is as a risk factor for fracture, I do want to think about the type of falls that they're having, specifically the number of falls. So there's lots of different ways that you can classify falls, and that is a whole lecture in itself. But one of the ways we can consider it is how often somebody is falling. Is this somebody who's had a one-off fall, like a once-only faller, and it's not a recurrent problem? Or is this somebody who is falling often, so 2 or more falls in a 6 to 12-month period? Because there is evidence that once-only fallers are physiologically much more similar to your non-fallers than the patients who have recurrent falls. Um, and some of the physiological markers that we see in recurrent fallers that are different are things like visual contrast sensitivity. They have worse visual contrast sensitivity, difficulty, seeing between objects. They have poorer reaction time. They have more body sway when they're static and when they're walking. They have weaker quadriceps, and they have poor vibration strength and sense. And all of those things come together to increase their risk of falls. So it is the patients who fall, kind of recurrent falls, who are going to be at higher risk than the patients who just have the kind of one-off fall. And there are studies looking specifically to see whether falls in and of themselves are an independent risk factor for falls over and above what your bone density is. So this is a study that was part of the study of osteoporotic fractures, or SOF research group, and they followed a large cohort of white women longitudinally to see what were the risk factors that predicted for hip fracture. And they did find that falls in the previous year was an independent risk factor for falls. And if you looked at people who fell recurrently, up to 5 falls each fall increased their risk of hip fracture by 30%. And then when they analyzed a subgroup of women who did not have osteoporosis on bone mineral density, so they didn't reach that threshold of a T-score of minus 2.5 or below, there were 3 risk factors that increased the risk of having a hip fracture. So one of them was history of falls in the last year. Second is reduced visual contrast sensitivity, which we talked about as a risk factor for recurrent falls, and also lack of exercise and deconditioning. Another study was done as a meta-analysis of the Mr. Oz study. So specifically, again, looking at the question, do falls predict future fractures independent of the FRAX score? So this was a meta-analysis of the three Mr. Oz cohorts that were in the US, Sweden, and Hong Kong. And here I've listed the number of patients that were a part of each cohort and also the average age of the participants in each cohort. And they found that past falls history predicted fracture across all the cohorts. And that was any site fracture, major osteoporotic fracture, and also hip fracture. And when they adjusted for FRAX, that independent relationship between history of falls and incident fracture remained. So the summary is that if you have a history of falls, that predicts incident or fracture independent of FRAX. So that needs to be taken into account, and their FRAX score may be underestimating their actual risk of fracture. And this we can see reflected in the guidelines and recommendations from Osteoporosis Canada. So one of the top 5 reasons to treat moderate risk patients is if they have recurrent falls, specifically if they've had 2 or more falls in the past year, so the recurrent fallers. So that's the fallers. Now I'm going to move on to dementia. So if my patient has dementia, does that affect their risk? Now, this can often be a tricky situation, particularly as patients have progressive and more advanced dementia, because then you're thinking about, what is their overall prognosis? You're thinking about burden of medications. As I mentioned, we're often trying to take away medications. Do I really want to add medications to uh, increase their polypharmacy? Are they going to derive benefit from this additional treatment? Is the benefits of the medication going to outrisk the potential side effects of the medication? And sometimes we kind of end up in the position where we just think, well, they're not on any treatment at the moment. Let's, not rock the boat and not start anything for now and see what happens. So I just wanted to outline some of the factors that link dementia to hip fracture and actually illustrate how patients with dementia are actually at higher risk of fracture than their age and sex matched peers that are cognitively intact. So, from an epidemiological perspective, we know that both of these conditions happen predominantly in older adults and specifically in the oldest old. So I outlined earlier how your risk of fracture and specifically hip fracture increases with age. The similar pattern can be seen with dementia. Um, we know that patients with dementia tend to fall. Up to 80% of patients with dementia fall on a regular basis. They average 3 falls a year, and patients with dementia are 8 times more likely to fall than their cognitively intact peers. And I hope I demonstrated to you earlier that falling is a huge risk factor for hip fracture. Of the patients who do present with hip fracture, 40% of them have underlying dementia, and that's usually, known diagnosed dementia. We often find patients that we see through geriatric consult having had a hip fracture who likely have had underlying dementia for quite some time, but it has just never been picked up and clinically diagnosed. And when you have been diagnosed with Alzheimer's disease, over the next 10 years, your risk of having a hip fracture is over 2.5 times those of your cognitively intact peers. So dementia is very strongly related to fracture and specifically hip fracture. This is a theoretical model that I really like that really shows the relationship between dementia and hip fractures. And I know it's kind of busy, and I'll just break it down for you a little bit. So up here we have shared risk factors between dementia and hip fractures. So these are things that are going to predispose a patient to both dementia and hip fracture. And that includes things like demographics. So the older you get, we just mentioned, the more likely you are to develop dementia or hip fracture. Then you have things like lifestyle, and that's, smoking, excessive alcohol intake, both of those, and reduction in exercise or lack of exercise. Both of those things will predispose to both of those conditions. Vitamin D deficiency, and there's something called the apolipoprotein E4, which is a gene that predisposes to Alzheimer's dementia and has also been implicated in fracture as well. So these things have shared risk factors between the two. And then you have your medications down here, which almost directly links your dementia to your hip fractures. And these are medications that are more commonly prescribed in patients with dementia. which leads to falls and fractures. So the two common categories that we talk about would be medications specifically for treatment of Alzheimer's dementia, and those are your cholinesterase inhibitors. These may be drugs like donepezil, also known as Aricept, rivastigmine, or galantamine. And one of the potential side effects of those medications is that it can cause a slow heart rate or bradycardia, and it can also cause conduction system defects within the heart. So it can cause rhythm disturbances. And both of those things can affect your blood pressure and cause symptoms like dizziness, which in turn can lead to falls. And it can also cause syncope or cause patients to pass out because of the disturbances to the heart. And if you pass out, by definition, you end up on a lower level and you will fall. And if you fall more often, you're more likely to break a bone. The other thing that patients with dementia often suffer from is something called behavioral and psychological symptoms of dementia, or BPSD. And the prevalence of this can be upwards of 90% during the course of a patient's uh, dementia. And those include the neuropsychiatric symptoms that we see. So that can be anything from anxiety, depression, and apathy, or agitated behaviors, as we call them sometimes, like pacing and wandering, all the way through to visual hallucinations, fixed delusions, and psychotic symptoms. And because of the prevalence of BPSD, patients are often medicated to try and treat these symptoms, even though we know that the evidence for these treatments are not necessarily robust. So they're more likely to be on treatments like antipsychotic medications, anxiolytics, benzodiazepines, antidepressants, and there is a known and strong association between those classifications of medications and falls, and they actually are within a category of medications that we call FRIDs, or falls risk inducing drugs. And because there's a higher prevalence of those drugs, they are more likely to fall. And if they're more likely to fall, they're more likely to fracture. Um, and then you have a whole host of these intermediary risk factors which interact to link dementias and falls. So in a way, because dementia is quite a complex disease, and sometimes clinicians are a bit hesitant to start new medications for a problem that hasn't occurred yet, like a hip fracture, these patients are often actually at higher risk and may be of greater benefit to be on bone protective therapy compared to their peers who don't have dementia. So I hope that was a good overview of dementia and the reason why we need to consider bone protective therapy in this patient population. So if we go back to our clinical case, going back to some of the features that we saw, well, on FRAX, he comes up at moderate risk for major osteoporotic fracture. He just tips into high risk there for hip fracture. But the things that we want to take into account as well is that he's a recurrent faller. He's fallen 4 times in the last 6 months, and with each fall, he's increasing his risk of hip fracture by 30% if we are going to look at the soft study. And because of his dementia as well, he's forgetting to use his walking aids. He's not necessarily aware of his environment. He's going out when it's snowing, when it's icy and it's slippery. And so all of those things are factors that are not incorporated in FRAX, which will significantly increase his risk of fracture. So this is a man that I would definitely treat. So the last thing I just wanted to touch on is the role of geriatrics in hip fracture care. And this is the concept of ortho-geriatrics, and how ortho-geriatrics is a complement to the fracture liaison services in our aim to reduce the osteoporosis care gap. So this is our case finding pyramid, so our systematic approach to fracture prevention. And here at the very top, we have our hip and spine fractures. So these are the patients that we should be case finding and targeting our secondary prevention to try and reduce the risk of further fracture. And this is where our fracture liaison services are very helpful. And I know Osteoporosis Canada has been working very hard at increasing the number of fracture liaison services across the country to help close this osteoporosis care gap. Now, hip fracture patients are very different from some of the other patients that we see. So, I do a post-fracture clinic that case finds from our hand and upper limb clinic here in London. And, my 50 to 60-year-old, active lady who tripped while golfing and sustained a distal radius fracture is very different from the patient that I often see on the orthopedic wards who's had a hip fracture. They're often older, they're frailer, and they have lots of falls as well as on their underlying osteoporosis. And they often have a number of comorbid medical conditions as well. And with a hip fracture patient, they need to have an operation, which is very different from the majority of our non-operative patients or non-operative fragility fractures. And not only do they need to be optimized for the surgery, they need to try and make it through the surgery. And there's a whole host of post-operative complications that are potentially waiting for them, be it medical complications, surgical complications, uh, decompensation of existing chronic medical conditions, or iatrogenic complications like the development of pressure sores. And they're also at higher risk of loss of function. So you need, people who are trained in looking at activities of daily living, rehabilitation, working together with the interdisciplinary care team. And as much as I love my orthopedic colleagues, I think we all know where our strengths are. If you gave me a hammer and chisel and you put me in an OR, I would not have the first clue as to how to do a dynamic hip screw. And in a similar fashion, I wouldn't necessarily expect my orthopedic colleagues to be able to manage all the complex medical complications that can happen after their hip surgery. So this is really where ortho-geriatric care was born. It was a recognition that shared care leads to better outcomes. So ortho-geriatric care is really the medical care of older patients with orthopedic disorders, provided collaboratively by geriatricians and orthopedic surgeons. And I should also mention a whole host of the interdisciplinary team, specifically catering for the needs of the older adult. And what makes geriatric medicine different from internal medicine is the comprehensive geriatric assessment. So it really is multidimensional. We don't just focus necessarily on the medical aspects, but we look at the person as a whole, and we look at them from a medical aspect. We look at a lot of their psychological conditions. So as I mentioned, dementia is very common. The 3Ds, dementia, delirium, depression, are things that we are trained to manage. And a lot of those things can manifest in the post-operative period, and we work very closely with our geriatric psychiatry colleagues should the needs arise. We also focus on the functional and the environmental as well. So working with our allied health, our physiotherapists to try and set realistic goals for our patients whilst taking into account their medical and psychological problems, working with our occupational therapists to see if environmental adaptations could be employed to improve their functional status, and also working together with our social workers and our home care to try to optimize our patients' abilities to be able to return to community living if at all possible. And in the orthogeriatric unit that we work at, we have weekly interdisciplinary team meetings with our allied health, with our orthopedic pharmacists, orthopedic nurse practitioners to close the loop on all of these things. So these are the three pillars of orthogeriatric care that have been set out by the Fragility Fracture Network, and it spans the whole continuum of the patient journey. So is geriatric involvement in the acute care co-management when they're, in the throes of their hip fracture and the perioperative period. It's input into their rehabilitative care to try and maximize and optimize function so that they can return to a baseline if not possible, if at all possible, or optimize their ability to be as functional as they possibly can over the long term. And in the third pillar, secondary prevention, this is falls and fracture secondary prevention. And this is where orthogeriatrics can work collaboratively and very closely with fracture liaison services to reduce that osteoporosis care gap. And geriatricians in countries which have orthogeriatric care embedded within it, one of their mandates is to investigate for secondary causes of osteoporosis and to start osteoporosis therapies, preferably prior to discharge, as we see in the 3I FLS model. And in that patient journey, there are lots of opportunities for the geriatrician to be involved. It is also very helpful for continuity of care as well, for somebody to be seeing them consistently throughout their journey. And I'm very happy that here in Ontario, the importance of the geriatrician or treating patients with the principles of geriatric care has been recognized and embedded within the quality standards for hip fracture care as published by Health Quality Ontario back in 2018. And this is one of the things that we are working towards in my local center, Ontario-wide, and hopefully nationally as well. So what does orthogeriatric care look like, and what are the potential outcomes? These are the three commonest cited models of care. So the first one isn't really a model of care, this is just usual care. So what happens then is a patient is admitted under orthopedic surgery, and eventually at some point geriatrics is consulted if and when orthopedics deem it appropriate. And then in my own experience, that is often when things have gone wrong, or the patient is now very delirious, or they're not progressing with rehabilitation in the way that we would expect them to. And if somebody is not automatically consulted and we don't have a fracture liaison service and internal medicine are not involved, there's a lost opportunity there for osteoporosis secondary prevention. Um, the commonest model, or one of the commonest models, is the orthogeriatric liaison model, which is what we have in our hospital, where the patients are admitted to orthopedics and we have proactive, regular review by geriatrics for all of those pillars, with multidisciplinary input. And there's good evidence that you have reduction in patient mortality, you can reduce length of stay, and reducing a whole host of postoperative complications. The next model is an expedited transfer to geriatric rehabilitation units. So the orthopedic surgeons very much, do the hardware and then transfer MRP over to geriatrics. And that has been shown to increase somebody's ability to achieve independence or less dependence for activities of daily living and mobility, which is what rehabilitation excels in. And then you have your all singing, all dancing joint model of care, where you really have true shared care of the patient by orthopedic surgeons and geriatricians and they're both joint MRP. And again, we have evidence of improved mortality, reduced length of stay, and reduced postoperative complications. Which model is the best one? We're still not quite sure. The evidence is out on that. There's been several meta-analyses that have been done, which haven't really been able to delineate which of these models is the best one. But the one thing that they have agreed on is any model of orthogeriatric care is better than usual care. And if you would like to learn more about fragility fracture care, be it hip fracture or any of the different types of fractures across the continuum of clinical care, I would encourage you to consider joining the Fragility Fracture Network Global Congress, which was meant to be in Toronto in 2021, but unfortunately has had to be converted to a virtual conference. But it looks like it has a very good agenda, and I'm looking forward to it. So my key take-home messages for you really is that osteoporosis pharmacotherapy can be safe and effective in older adults at risk of fracture, and there's a high prevalence of conditions that are not necessarily embedded into our standard fracture prediction tools that should be taken into account that increase an individual's risk of fracture, and that orthogeriatric involvement improves outcomes in older adults with hip fracture and is a complement to fracture liaison services to achieve a shared goal of reducing the osteoporosis care gap. So thank you very much for listening, and I'm happy to take any questions.
Thank you so much, Dr. Thain. I have one question that's posted already, and I'll let others think about any questions they have. We have about another 10 minutes. So I'll read them to you. I'm not sure if you can see it or not, but it says, regarding the projection of the increase in hip fractures from 1990 to 2050, more about osteoporosis now with diet, exercise, and medication than we did in 1990. So how reliable are these projections? Shouldn't things improve?
So I think that you're right. Things have changed a lot from 1990s. And as far as I'm aware, those epidemiological projections haven't been updated. There is a lot to be said about diet, exercise, and medication, but diet and exercise, I don't know what everybody else's experiences are. are very difficult to implement. And there is a lot of research going on about how to keep people motivated to do these things beyond the acute care period. With regards to medications, yes, there are a lot of medications out there, but we do know that there's still a huge gap in the number of people who are not getting medications. So, for example, there was, I haven't shown it here, but I know the Ontario Osteoporosis Strategy looked at the treatment rates of hip fractures in Ontario, even just a couple of years ago. And some of the LINs within Ontario, like over 80% of patients who have had a hip fracture have not been treated 6 months after their hip fracture. And that's not only have they not been treated, they also haven't had a bone density, so they haven't been investigated or treated. And that is kind of in keeping what we find with the literature. I would say also that kind of there was a big hit to osteoporosis, the uptake of osteoporosis therapy. I want to say in the mid 2000s when all that concern about atypical femoral fractures came up, and a lot of the benefits that we saw with uptake in therapy did wane, and we're working on trying to increase that again. There is evidence that the incidence of hip fracture is declining, but with the huge number of older adults projected, all the baby boomers are now in their older years, they're all kind of geriatric now, is just the sheer number of older adults that are coming out is driving an increased prevalence of hip fracture. So I hope that answers some of that question.
Thank you very much. There are no other questions listed there right now, so I will talk slow in case another one comes in. But thank you very much for giving us your time and your knowledge. And I really liked your five M's of geriatric medicine. I think that was a great visual, and I thank you for all your work in trying to reduce the osteoporosis care gap in Ontario and beyond by joining us today. I'm going to check one more time for any new questions. No questions. So there is a survey coming out. If you think of something you'd like to ask Dr. Thain, then certainly put it in the survey and I will do my best to send it along to her, and she will do her best, I'm sure, to find some time to answer that. But in the meantime, thank you all very, very much. And thank you especially Dr. Thain for your time. And I hope everyone has a great and healthy day. And remember to wash your hands. Thank you, everyone.